Good evening, everyone. This is Meldita, and I'm here again at my YouTube channel, MELDITA'S Info Corner. My Facebook is johnregacho@yahoo.ca. Okay, so we're done with our lengthy renal videos. So soon we're gonna have our atrial fibrillation video, but right now let's take a break. So inferior Stemi with Vtach arrest. So I have here a 50-year-old man. Okay, diagnosis is inferior Stemi with Vtach arrest. And his chief complaint is severe chest pain. And this happened while watching TV for 1 hour. He felt sudden severe chest pain, 10 over 10, scale 1 to 10, 1 as the least and 10 as the most painful. His pain is at 10. His wife called 911. ALS hooked the patient to the cardiac monitor, and it showed inferior ST elevation and anterior ST elevation. They loaded the patient with aspirin, 320 milligram PO. If they have the protocol, they can give either Plavix or ticagrelor. If they don't give it, then the cath lab nurse will do it. Okay? So aspirin, Plavix, or ticagrelor, they are both antiplatelet, but they work on different pathway, but their aim is to prevent thrombosis. Also, they give the patient morphine sulfate for pain en route to a tertiary hospital with their cath lab. Cardiac risk factors, he's an ex-smoker and obese. And he did not tell the nurse when he stopped smoking, and other history quit alcohol. And he did not also tell the nurse when he quit alcohol drink. So this is the ECG of the patient. Atrial fibrillation, we have ST elevation on inferior leads 2, 3, and F. We have also anterior ST elevation 1, B1, B2, 3, and 4. This ST elevation from the inferior is coming from the R wave. The ST elevation coming, for the anterior, the ST elevation is coming from the S wave. There is also B4R. Maybe they're trying to investigate RV involvement, but they should have included D3R as well and B4R together. And sometimes if you have ST elevation in the AVR, then you have to proceed with B3R or B4R for potential RV infarction. B8 and B9, they're both done, but they're negative for posterior STEMI. So the patient went to the cath lab. Before the angiogram, the patient arrived in the cath lab, still on the stretcher with a defib monitor, and went to cardiac arrest. This is a polymorphic Vtach. Okay, they defibrillated the patient 200 joules one time using biphasic defibrillator. The patient converted to atrial fibrillation, but there's no more ST elevations. Okay, so then they give also amiodarone to the patient, proceeded to the to the cath lab room. On the table, angiogram done, and the interventionalist cardiologist saw that the patient has a blocked right coronary artery, and you put 2 stents, okay? And we have an ejection fraction of 40% and EDP of 20. The normal 40% is, the normal EF is actually 55 to 75 or 60 to 80. But they said 50% is acceptable. So his EF is 40%, so it's low. And ejection fraction, actually, that is the fraction of left ventricular and diastolic volume from the left ventricle ejected during systole. His EDP is high, 20. The normal number is actually 3 to 12. Okay. And left ventricular and diastolic pressure is actually the completion of diastolic filling before systole, or the final volume at the end of the diastole before systole. So it's kind of high. They said 15 is acceptable. The doctor will probably give 20 or 40 milligrams of Lasix, and also the patient is on AFib. Okay, but not all patients with high EDP will get Lasix. Okay, so then the procedure is finished. The doctor used the radial approach, TR band at the right radial side, okay, and the patient is started on amiodarone infusion, which is antiarrhythmic, class 3, is a potassium blocker. Okay, so went to CCU, an hour after, 12-lead ECG is done, and this is what we see. No ST elevation inferiorly and anteriorly, but there are inverted T waves on inferior leads 2, 3, and F. And in here, There's none, but there's a T-wave inversion before 5 and 6. Okay, so the amiodarone infusion is ongoing, and early morning, the patient converted to sinus rhythm. Okay, here we go. Now it's sinus at 60, and we still have an inverted T waves on lead 2, 3, and F inferiorly. Anteriorly is the different one. A while ago it was 4, 5, and 6, but now it's a little bit T wave inversion V1, 2, and 3. Okay, then they will reassess the amiodarone in the morning. Okay, so when the patient came in, we noticed that we have ST elevation 2, 3, and F. So that jives with a blocked right coronary artery, and that has been stented. However, when we look at this ST elevation in V1, 2, and 3, and 4, we suspect that there might be an LAD occlusion. Well, in this case, there's none. Okay, so only the RCA blocked. We have ST elevation in here, and this one, LAD is clear, but we have ST elevation earlier before the angiogram. I'm a little bit puzzled here because when the patient arrived in the cath lab, went into polymorphic Vtach and defibrillated, we have this AFib. So there's no more ST elevation. Normally, if a patient comes in with ST elevation, we see that their STs will start to gradually go down after the stent is inserted. But in this case, no stent is inserted, STs resolve all throughout, but also converted to a good rhythm, which is sinus rhythm. This reminds me of a patient that I admitted in the past with Prince-Metal angina, which is a vasospastic coronary vessel. So his coronaries will go into spasm, and that will block the blood flow, of course. So we call it the Prince-Metal angina, and usually it happens during rest. They did an angiogram, the coronaries are clear. But if the Prince-Metal goes long and everything, you prolong also the you prolong the no flow. If a prolonged Prince-Metal happens, there will be no flow to the heart muscle, and you can actually induce the patient into myocardial infarction. So what they do with Prince-Metal, they usually give them nitrates or calcium blocker. So the question is, I'm puzzled why this patient is a Stemi and suddenly we lose it. There's even no stent put in yet. So good question. So let's go back to the history. Is there something that the patient did not telling the nurse? There might be something that he did not tell the nurse. We don't know what he smoked or anything, So I'm a little bit puzzled because usually, as I said, STEMIs, they come and then usually they start, after the stent put in, they start, going down with their STs, their ST elevations coming down and everything. And in the morning, you see them already inverted T-waves. So they have evolved. But in this case, it suddenly disappears. So I'm puzzled what's going on in here. Is it there some sort like maybe a little bit of Prince-Metal? But in this case, we have a blocked right coronary artery. So in Prince-Metal, you don't have blocked coronary arteries. They're normal. Their only problem there is the vessel will go into vasospasm. It blocks the flow because you go into spasm. But when the spasm is gone, it opens up. Here, it's blocked. You have to open up. So this is a question that I still have to verify with the doctor what happened here. Okay? And probably I will be giving you more examples with interesting ECGs. Thank you so much.